is the oblique fissure, right? How do you mark the fissure is you are going to see in my body the left lung is placed like this. Okay, this is the anterior border and this is the cardiac notch. You can see the cardiac notch here, and this is the lingula. If it is showing the lingula, there are two bronchopulmonary segments, superior and inferior lingular segments, right? And you have to remember it represents the middle lobe of the right lung morphologically, right? Then you're going to see the anterior border here, sharp anterior border, and the oblique fissure. If I clip the lung like this in my body, it starts from posterior aspect. The junction between third and fourth thoracic vertebra, you are going to draw a line from back, right? That is from the back all the way coming here. This is the mid-axillary line. This oblique fissure reaches at the fifth rib in the mid-axillary line, and if you trace it down, as you go down, it goes to the sixth rib at 9 centimeters away from the mid-clavicular line, right? So that is how the oblique fissure is obtained, by joining these 3 points. If you want to draw the horizontal fissure, this is the horizontal fissure, what you are going to see here. This is the horizontal fissure. Now this starts at the fourth costochondral junction and it touches the fifth rib at the mid-axillary line. That is how you, by joining the 2 points, fourth costochondral junction in front, you understand what is costochondral junction, junction between the rib and the cartilage, fourth rib, and you draw an horizontal line which cuts the oblique fissure at fifth rib at mid-axillary line. Okay, so what is very important is 3 lines are very important to remember: the mid-clavicular line, mid-axillary line, and the scapular plane, right? These 3 becomes a basic landmark for all this to draw the oblique fissure and the horizontal fissure, as well as if you want to trace the inferior border of the lung and the inferior border of the pleura. So always remember, inferior border of the lung is 2 ribs above the inferior border of the pleura, right? So inferior border of the lung is at 6th rib in the mid-clavicular line, 8th rib in mid-axillary line, and 10th rib at the scapular plane. If you join these 3 points, you are going to see the inferior border of the lung, whether it is on the right or left side. 6th at the mid-clavicular line, 8th at mid-axillary line, and 10th at the scapular plane. 2 ribs below, 8th rib at the mid-clavicular line, 10th rib at the mid-axillary line, and 12th rib at the scapular plane, you are going to obtain the inferior border of the pleura, right? So 2 things are very important to remember: the inferior border of the lung and pleura, and to draw the oblique and horizontal fissures, and also another one is the anterior border of the lung, to differentiate between the cardiac notch lingula from the right lung, right? Now also you have to remember all the bronchopulmonary segments. We have told 10 bronchopulmonary segments in each, where they are situated and what is its clinical importance, right? And also I have told in the class about the 4 different stages of the lung. Very important is the action of the innervation of the lungs. Thank you. Yeah. So not the lungs which I kept saying.
No.
Very good.
I just had to try it.
Now somebody asked me about the impressions of the lung. Now impressions is very difficult to identify all these things. What is very prominent, you identify anything. If you see the left lung or right lung, this is the hilum you are going to identify. First and the foremost point, when you identify the hilum, you have to identify the difference between artery, vein, and the bronchus, right? Always, you see, this is the bronchus, you see the cartilage is present. If I touch the rough surface, you'll see the cartilage. See, what I am holding is the cartilage now. A piece of cartilage is there. That is the bronchus. And see the wall of the artery, that the pulmonary artery is very thick and the lumen is patent. See this one, the wall is very thin, lumen is collapsed. The walls of the arteries are thicker than the walls of the veins, and the lumen is always kept patent, open. Lumen of the veins will be collapsed because the thin walls, right? And on the walls of the bronchus, you are going to see the presence or absence of the cartilage, right? When you trace the same thing, when you compare with the histology slides, now if you trace the bronchus, always you are going to see the hyaline cartilage will be present. Now in the slide you must have seen how to differentiate bronchus and bronchiole. For example, in the exam, if it is focused, pointer is showing the bronchiole, we should be able to differentiate the pointer which it is showing whether it is a bronchus or bronchiole based on presence or absence of the cartilage. If you find the cartilage, then it is a bronchus, right? So that is another one. And always in front of the hilum of the lung, whether it is right or left lung, here you see the halo depression, that is the cardiac impression. Now the cardiac impression, if you take the right lung, cardiac impression of the right lung, right? So here it is formed by the right atrium and right ventricle, separated by the pericardium and pericardiophrenic nerves and vessels, right? Pericardium and pericardiophrenic nerves and vessels separates the lung from the heart, that is the cardiac impression. Now, in the right lung, you are going to see, this is, if you observe carefully, you can clearly see the groove. See this depression here, this is the cardiac impression, right? Everyone can identify this vertical groove. This is the groove for the inferior vena cava. And same way, you can see this vertical groove here. If it is pinned here, see the depression, you can clearly see this groove for the superior vena cava. And also clearly you can identify this depression, that is the arch of azygous vein. So at least you can identify cardiac impression, groove for inferior vena cava, groove for superior vena cava, arch of azygous vein. So by closing your eyes, you can tell this is the medial surface of the right lung. It's always related to the trachea, right? It is related to trachea, separated from the right vagus and right phrenic nerves. If the same thing, if you're seeing on the medial surface, no need to work for the search for the impression. It is related to the trachea, esophagus, and also the subclavian artery, right? And here, if you see the left lung, see this one, the very prominent depression here, descending aorta, and this one you can see the arch of aorta. And if you carefully observe, there is a depression continuing here and here. That is a groove for the left common carotid artery and left subclavian artery. If you see this part, descending aorta is present, arch of aorta is there, but it is not that much prominent here, right? Here also, first and the foremost thing, whenever you see the hilum, see the bronchus, artery and vein. That is one thing you have to identify, right? And this is the cardiac impression you can clearly make out. So other impression is not that much, this one, it is not prominent. Descending aorta, arch of aorta, arch of azygous vein, superior and inferior vena cava impression, and most of the lungs, you see the prominent groove for common carotid artery and subclavian artery. And also remember, I am showing this place here where the common and subclavian artery is related. In the given exam specimen, it will be very clear. No need to get confused. Impressions will be very clear. If it is asked for the impression, any question, you have no need to worry about that. We are not going to keep any specimen which is not, which make you confused, right? Then, anything else you want to ask in the lung? Clearly, innervation, blood supply, innervation especially and its action, bronchopulmonary segments, impressions, right? And hilum. And this is what we see. This one, what I am holding is the double layer fold of pleura here, below the lung. This is the pulmonary ligament. So it will be clear in the exam specimen. It is not that much clear. You can see here also the double layer fold of pleura, that is a part of this coming from the lung, right? Now here, if you see the specimen, you are going to identify, as I told you in the last meeting, that is bones forming the nasal septum is important, bones forming that is the blood supply and nerve supply to the nasal septum is important, right? Anastomosis around the little area is important, which artery takes place. And same way, structures opening in the meatus, you have to be very familiar. If they ask, identify the probed space, name the structure opening in it. You should be able to tell which space is that, whether inferior meatus, superior meatus, or middle meatus, right? In the inferior meatus, you see the nasolacrimal duct. Middle meatus, you see the maxillary sinus, anterior, that is the frontal air sinus, and the ethmoidal air sinus, middle and posterior ethmoidal air sinus, right? Or anterior ethmoidal. So then you are going to see the superior meatus, and identify this one. This is the sphenoidal air sinus, which opens in sphenoethmoidal recess, not in any meatus. It is opening in the sphenoethmoidal recess. I want you to be familiar with the blood supply and nerve supply to the lateral wall of the nasal cavity. And in the multiple choice question in the final exam, they can ask the bones forming the lateral wall. You should be familiar with bones forming the medial wall and the lateral wall of the nasal cavity with arterial supply and the nerve supply, right? And you all know that it is lined by the respiratory epithelium, and this area is called the vestibular area and the lateral wall of the nasal cavity, and this depressed area is the atrium of the middle meatus, and this is the nasal cavity proper. So nasal cavity is having three parts: vestibule, atrium of middle meatus, nasal cavity proper. In the nasal cavity proper, you see the elevation and depression in the form of concha and meatus, right? And if I put the forceps here, this is the demarcation. If I pass the finger behind this, that is what you call the posterior nasal aperture, through which the nasal cavity communicates with the nasopharynx. This is the nasopharynx you entered. Important characteristic feature, identification of opening of the auditory tube. That is the opening of the auditory tube, which communicates with the middle cavity and the nasopharynx, right? And above the opening, this what I am holding is the tubal elevation or torus tuberalis. And anterior, this fold, what I am holding, this fold is the salpingo-palatine fold produced by tensor palatine muscle. Salpingo-pharyngeal fold, which I am holding here, this is a salpingo-pharyngeal fold produced by salpingo-pharyngeus muscle. Salpingo-palatine fold, see the fold is clearly here, produced by tensor palatine muscle. Salpingo-pharyngeal fold is also very clear, produced by salpingo-pharyngeus muscle. This is the tubal elevation. This is the opening of auditory tube. And this is the pharyngeal recess. In the deep to the pharyngeal recess, you are going to see the internal carotid artery will be present, right? So this is the nasopharyngeal isthmus, where the nasopharynx continues with the oropharynx. And identification in the oropharynx, see this one. Now you are seeing the lateral wall of the oropharynx. This is what I am pointing is the tonsillar sinus, where the palatine tonsil will be present between the palatoglossal fold and palatopharyngeal fold. Tonsillar sinus is bounded in front by palatoglossal fold, which is produced by palatoglossus muscle, and behind palatopharyngeal fold produced by palatopharyngeus muscle. Between the two is the tonsillar sinus or the tonsillar fossa, where the palatine tonsil is present. And you have to be very clear about the structures forming posterior relation or the bed for the palatine tonsil. Structures forming the palatine bed for the palatine tonsil, that is the pharyngobasilar fascia, buccopharyngeal fascia, superior constrictor, tonsillar artery, glossopharyngeal nerve. All these structures forms structures behind the palatine tonsil or bed for the palatine tonsil, right? Whenever you do the tonsillectomy, you have to be very careful about the paratonsillar vein, which always gets ruptured, results in continuous bleeding. Remember, tonsil is the only area or two areas in the body is there. After, usually when there is a blood, when there is a damage to the any wound appears in the body, we encourage clot to form to stop the bleeding, right? When there is a bleeding, we encourage clot formation. But this is the area where after tonsillectomy, we don't encourage the clot formation. We always clean this area in order to bring the paratonsillar vein to close the paratonsillar vein, right? So in this area, and after the hysterectomy, that is after removal of the uterus, there also they don't encourage the clotting. If clotting is encouraged, there will be some leakage of the blood continuously. So they clean that area after hysterectomy and the tonsillarectomy in order to stop the bleeding, right? So structures forming the tonsillar bed, paratonsillar vein, pharyngobasilar fascia, buccopharyngeal fascia, superior constrictor, tonsillar artery, and glossopharyngeal nerve, right? That is the oropharynx. When you come to the laryngopharynx, I don't know whether laryngopharynx has been done. This is the laryngeal cavity. Behind this, what you are seeing, this gap is the laryngopharynx. And very important part, you are going to identify this area is the pyriform fossa. Where deep to the pyriform fossa, whenever you take the food, it gets accumulated in the pyriform fossa. So it can lead to the infection. The food debris can get infected here. So in order to clean the food debris, you have to be careful to not to rupture the mucous membrane. Deep to that is the internal laryngeal nerve is present. Any damage to the internal laryngeal nerve, it is going to affect the voice. So that is the pyriform fossa, right? So that is what you see in the laryngopharynx. Whenever you talk about the pharynx, you have to always stick on to the lateral wall of the pharynx, nasopharynx, lateral wall of the oropharynx, lateral wall of the laryngopharynx. In the lateral wall of nasopharynx, you find opening of the auditory tube, tubal elevation, salpingopalatine fold, salpingopharyngeal fold, pharyngeal recess, and the pharyngeal tonsil on the roof. These are the characteristic features. If you come to the lateral wall of oropharynx, that is the tonsillar fossa, boundaries of tonsillar fossa, structures forming the bed of the palatine tonsil. If you come to the pyriform fossa, it is that is lateral wall of laryngopharynx, that is the pyriform fossa, right? And this is the epiglottis muscle, epiglottic cartilage, right? And here is the arytenoid cartilage. The fold of mucous membrane between these two, if I stretch like this, there is a fold of mucous membrane, right? This is called aryepiglottic fold, forming the medial boundary of the pyriform fossa. This is the aryepiglottic fold, forming the boundary of the pyriform fossa, right? And this is the cavity of the larynx. You see the vestibular fold here, and this is the vocal fold, and this is the sinus of the larynx or the ventricle of the larynx. So sensory supply to the laryngeal cavity above the vocal fold, including the vestibular fold and vocal fold, above the vocal fold is the internal laryngeal nerve and superior laryngeal artery. Below the vocal fold, it is by the recurrent laryngeal nerve. Sensory supply is the recurrent laryngeal nerve, inferior laryngeal artery, branch of the inferior thyroid artery. Superior laryngeal artery is the branch of superior thyroid artery. Okay? So the nerve supply and the blood supply differs above the vocal fold and below the vocal fold. Again, I am repeating, above the vocal fold, it is the internal laryngeal nerve, superior laryngeal artery. The artery is the branch of superior thyroid artery. Internal laryngeal nerve is the branch of the superior laryngeal nerve. If you see the vagus nerve, the 10th cranial nerve, it going to divide into superior laryngeal nerve, recurrent laryngeal nerve, right? Superior laryngeal nerve further divides into external and internal laryngeal nerve. Internal laryngeal nerve supplies the upper part of the laryngeal cavity. External laryngeal nerve, you got to remember, it is going to supply the cricothyroid muscle. So only intrinsic muscle of the larynx supplied by the external laryngeal nerve is cricothyroid muscle, which tenses the vocal cord, right? So below the vocal fold, it is supplied by the recurrent laryngeal nerve. All the intrinsic muscles of the larynx are supplied by the recurrent laryngeal nerve, except cricothyroid, right? And in inferior laryngeal artery, which is a branch of inferior thyroid artery, right? So in the larynx, familiar with the cartilages, which are paired, which are unpaired. And remember about the membranes. Quadrate membrane is this one, and cricovocal membrane is this one, right? So quadrate membrane is the from the inlet to the vestibular fold. Cricovocal membrane below the vestibular fold, right? And intrinsic muscles, to identify in the model, you should be familiar with identifying the posterior cricoarytenoid, cricothyroid, lateral arytenoid, right? And transverse arytenoid. These are all the clearly can be seen in the models. With the when you identify, know the action, know the nerve supply. Nerve supply is common, recurrent laryngeal nerve, right? Know the action of these muscles. Anything else?
You said that there was a abrupt change in the epithelium. Where is it? The vocal fold, the vestibule, or the...
So when you see the epithelium from the nasal cavity is lined by respiratory epithelium and olfactory epithelium. If you come to nasopharynx, stratified squamous epithelium. So it continues up to the larynx. Below the vestibular vocal fold, respiratory epithelium again, especially it is a pseudo-stratified ciliated columnar epithelium continuing down in the trachea, all the way up to the terminal bronchioles, that is respiratory bronchioles. Then you see the terminal bronchioles, then you come the respiratory bronchioles, right? So there it is changing into cuboidal epithelium. Then in the alveoli of the lung becomes squamous epithelium. Anything else? So if you go to the plastinated specimen, identify all the accessory muscles like scalenus anterior, medius and posterior, serratus anterior, serratus posterior, pectoralis major and minor, right? All these are the, you take a list of respiratory muscles, which are main respiratory muscles, like diaphragm. Once you identify diaphragm, see the 3 openings and structures passing through openings. Once you see the accessory muscles list, you try to identify all these muscles, right? And know the ribs, first and second rib properly. Know the, especially that is the atypical rib, right? And know the vertebrae also. So different parts, it can be asked in the X-ray also, different parts of the vertebrae. You have seen the X-ray picture, right? Anything particular you want? X-ray now do not have.
No X-rays. Anybody else
How is
have
that?
questions? That's good.
X-ray has been sent to Dr. Ochinako to select which is going to be coming in this quarters. So I don't have X-ray.
He can see what X-rays, so yeah.
Okay then, all the best.